So we've already talked. We've already used the terms upper motor neurons. I told you the cerebral peduncles are really just a large collection of the projection fibers that are the upper motor neurons. We leave some of them behind where they synapse with the pontine nuclei, and those go out to the cerebellum. The rest descend, and that's what forms our medullary pyramids. So the upper motor neurons and the cerebral peduncles continue down and form the medullary pyramids. Same neurons. That's why we have the medullary pyramids. And then they descend down to the anterior great horn. And our anterior great horn is made up of lower motor neurons, which pass out the ventral root and go either into the ventral ramus or the dorsal ramus. So what happens if we have a lesion to the upper motor neuron? Let's say we lose blood supply, the vertebral artery is blocked, and we lose blood supply to our medulla and posterior, let's say we do it up here, make it easier, at the midbrain. Okay, so posterior cerebral artery, some of our branches of basilar artery are lost. And we have our lesion at the upper motor neuron before it crosses. So is our paralysis going to be on the same side of our lesion or on the opposite side? Same side or opposite from our lesion? Follow the pathway, crosses over. So our paralysis is over here. The origin was over here, so it's contralateral. So it's the reverse of sensory, because now we're descending. Okay? So, and you can visualize it. So if our lesion is before it crosses, the origin is contralateral, and the lesion is contralateral to our loss of function. So if the lesion is above the level of decussation, then we have contralateral. If our lesion is below the level of decussation, then we have ipsilateral, because it's already crossed over. Is this flaccid or spastic paralysis if our lesion is of the upper motor neuron? Flaccid or spastic? Is our lower motor neuron still intact? Yes. So what happens with our sensory neuron is if our sensory neuron is activated, let's say that, the knee-jerk reflex. So a sensory neuron comes in, and synapses with our lower motor neuron, it can still activate it. And you would still have movement. You wouldn't be able to consciously decide to kick somebody, all right, or move just your fingers, but you would still have movement. And so if the upper motor neuron is damaged, for both cases, below or above the decussation, it is going to be spastic paralysis. Okay? It just depends on whether it's contralateral or ipsilateral, whether it's above or below. But it's always spastic paralysis if it's the upper motor neuron. If it's the lower motor neuron, the cell body's in the anterior great horn, it's always ipsilateral because it's already on that side. Okay, it's on the same side as the neuron is going to the muscle. That neuron doesn't cross. So, can I erase this? All right, so this is lower motor neuron. then it is always going to be ipsilateral flaccid, because there is no way of getting any current to the muscle itself. Okay? So a lesion of the lower motor neuron is going to result in ipsilateral flaccid paralysis. So that's two pathways down. And these are the two that we have conscious control of because it's cortical bulbar, cortical spinal. Consciously sticking my tongue out, consciously moving my eyeball, consciously smiling, consciously extending my arms or flexing my fingers or curling my toes. All right. The next three are called extrapyramidal, and they are unconscious stimulation, activation of voluntary muscles. Unconscious because it's below the level of the cortex. All right? So you have a blank piece of paper. I need to erase my marks. Before PowerPoint, I used to have this on a plastic overhead that I would just cover and then pull in a new piece of plastic. All right. So now the first one is tectospinal pathway, or the tectospinal tract. And this is the one we talked about when we looked at the superior and inferior colliculus. And we had some movement automatically caused you to move your eyeballs or turn your head, or a sound caused you to automatically turn your head. All right? So the word tecto refers to roof. So if this is the midbrain and pons and spinal cord, and here's the cerebral aqueduct, and cerebellum forming the fourth ventricle, what would these two structures right here be? Superior and inferior colliculi. Okay? And as such, they form the roof or tectum of the cerebral aqueduct. And so hence our tectospinal tract. All right? So the upper motor neuron is found in the superior or inferior colliculus. It just depends on whether it's visual or auditory stimuli. So I have it crossing over. It both stays on the same side and crosses over, but it's simpler just to think of it as crossing over. So this would be the superior colliculus. So it's going to activate what cranial nerve nuclei for moving the eyeball? Lateral rectus, abducens, so if I go look like this, ocular motor, or trochlear, depending on where my eyeball moves. All right? So those nuclei are in the midbrain and lower pons. So let's say that we go to the lateral rectus again, like we did before. And so it's going to cross over And I have this one going to ocular motor, but we'll send this one to the pons, lower pons. And one will not cross over. And that one's going to be inhibited because if we turn, we don't diverge our eyes, okay? But the neurons can go both ways. I'm going to draw this one fatter because it's the more prominent. I'll put this one as a less prominent pathway. And then it's going to synapse with the lower motor neuron. And that's our pathway.
I think that one should be the one with this.
So we have the upper motor neuron, and we have the lower motor neuron. Lower motor neuron pathway is exactly the same as it was for our cortical spinal or cortical bulbar tract. The difference is the origin of the upper motor neuron, because this is an unconscious pathway. It's a reflex pathway. What would be the sensory stimuli for this? Information from the optic tract. All right, so when it gets to the thalamus, it's going, some of it will go to the occipital lobe and some will be sent to the superior colliculus. Now, we also have some fibers that, so if it's inferior colliculus or even if it's superior, inferior you turn your head. All right, so in that case, we would pass through the pons, down the cerebral peduncles. Notice we don't cross over, because we crossed over already up here. And then in the cervical spinal cord, we would go to the anterior gray horn, to muscles involved in turning the head. So where that lower motor neuron is just depends whether it's eyeball movement or head and neck movement. The lower one would be spinal nerves. Oh, this one? This is abducens. But it could also stay up here for trochlear or ocular motor. Okay? So any of those three would be involved. So this is the pathway we talked about for the corpora quadrigemina. We already know what happens. If you hear something, you turn your head. Or if you see something, you turn your eyeball or your head. And so this is the tactospinal tract. All right. This is what neurologists have to be aware of when they are checking to see if someone is conscious or unconscious. So in the Terry Schiavo case 3 or 4 years ago, I don't know if you remember that, there was a woman who, according to media reports, had suffered some kind of, I don't know if it was a heart attack or a cerebrovascular accident, and as a result of anorexia nervosa and potassium electrolyte problems. And though her parents accused her husband of maybe some foul play, and they saved her life, but she was in quote-unquote a vegetative state. And there was conflict between the parents who wanted her kept on life support systems and her husband who wanted her taken off of life support systems. She had been on for like 7 years. And her parents swore that she responded to sound, that if there was a balloon in the room, she would turn her eyes or turn her head to follow it. And so the conflict was that voluntary movement, was she actually seeing that, or was it this type of extrapyramidal pathway where she wasn't processing the visual information in her occipital lobe, but it was a reflexive pathway of her eyes and head moving in response to something moving across her face or her visual field. And that would have been using this pathway, okay, without cortical involvement. Okay, so tactospinal coming from our word for the roof of the cerebral aqueduct. Okay, the next one is rubro.